All right. Hello, everybody out there. My name is Beth Holmes. I'm here today to talk to you about primary care and direct primary care in particular. Just to give you a little bit of overview about where we're going to go today, I'll give an introduction to myself so you can get to know me a little bit better. We'll talk about why primary care is important, what is direct primary care, and then how Hint Connect can help businesses implement direct primary care. Then we'll have time at the end for questions. So for most of you, I'm probably a stranger on the internet, so I'm going to try to humanize myself a little bit so you know kind of who I am, why I'm here today talking to you about direct primary care, and you can verify that I'm a real human. So what you're seeing is my family. I live in the Bay Area of California around San Francisco. I have 2 little girls and a husband. And I'm really passionate about healthcare. So I started my journey in healthcare at a nonprofit, kind of wondered, why are things so wacky that we need to raise money to pay for people's healthcare? Got a master's of public health and started working in health policy and contracting to try to implement risk-based contracts, working with primary care doctors who would take on risk for managing the cost of the population of their membership. And after several years of that, I was seeing that the doctors who were really good, who were set up in a way to be successful, had fewer patients, had really good teams, and had a strong model and good communication with their patients, knocked it out of the park with risk. And the ones who didn't really we weren't experiencing a lot of change, even despite our best efforts from the contracts we were putting forth. So I thought about it, and I think, there's got to be another way to support primary care in this system. And what I actually found was I had to go out of the system to Hint Health and work in a tech company supporting doctors working independently with their patients through direct primary care to really find that effective primary care space. So I'm really excited to tell you about it today. You're welcome to connect with me on LinkedIn. I'd love the connection, love to meet all of you who are here today. All right, so why primary care? I think everybody, you've heard so many times, primary care is important. It's the core of a health plan. It's the first place you should go. But statistically, when we look at primary care, it's more than just like a feel-good thing that people say. The more primary care that you see in any location, whether it's a county, a state, or a country, the better outcomes are, the healthier people are, the lower costs are. And unfortunately, what we see today in the United States is that U.S. adults are the least likely to have a longstanding relationship with primary care providers. This is for several reasons. One of the reasons is that we can have really big changes in the way our healthcare comes to us every year based on where we're employed, what our income is, how old we are. And so it can, even if you want to have a long relationship with a primary care doctor, that can be really difficult. Because your insurance can change. A lot of primary care doctors reaffiliate or leave the system. And then in terms of the plans that we have, PPO plans have really overtaken HMO plans in the past 10 years. People want choice. People want to be able to go where they want to go. It's a swing away from HMOs and kind of that control that the health system had. But in that swing away from the HMO control, people really swung away from primary care. And that's the wrong place to swing away from, because that's your medical home. That's the person who knows you or should know you. But we'll talk about the experience of primary care in the US. Unfortunately, that's not happening for everyone today. The effect of having inadequate primary care, what we see is higher emergency care, higher hospital care, higher end-of-life care, and higher specialist care. And many of you are probably familiar with what things cost now in healthcare. I come from a healthcare contracting background, so I've seen the prices, what health plans pay for many, many hospitals, many, many providers. When you take a look at what we pay for primary care, it is so inexpensive. It's really like the Costco versus the Gucci of what you're paying for healthcare. And it's really high value. When you go to somewhere like an emergency room for something that's not a true emergency, you're paying top dollar price for what's really unnecessary care. And without a primary care home, this is where we're spending our money as individuals, as employers, and as a society. And it's not efficient, and it's driving healthcare costs up. In societies or in places where you have great primary care, most people, when you develop that relationship with your primary care doctor, you can see primary care can address 80 to 90% of medical issues. Chronic diseases account for ballpark 80% of spend on medical costs, and they're really multifactorial. It's not just one thing that leads to people having chronic diseases or having unmanaged chronic diseases. It's so many things. It's genetic predisposition, it's where you live, even the weather, it's your lifestyle, it's your relationships, it's your mental health. And when the health system is fragmented and you're taking care of tiny parts of yourself with different doctors, it's inefficient, it's expensive, it's tiring, and you don't really get to a place of total health. You get to a place of one kind of whack-a-mole problem solved at a time. But primary care can look at it holistically and help you start with the root causes and work out from there to create real health for patients that primary care doctors work with. Why is this important to employers? Well, when we talk about costs and expenses to employers, often what we're talking about are medical costs, pharmaceutical costs, because that's the number that brokers and advisors are coming back with every year. The number, the amount that gets taken out of your paycheck for premiums, what your deductible is, what you're actually spending on healthcare feels like what the cost of good health or poor health is. But there's so much more than that. I think any of us who have been really sick, or even whether it's for a day, for a cold, or have been managing chronic pain or chronic diseases, know it's so hard to bring your full self to work or to your family or to home, anywhere you go, when you don't feel well. And so you can have workers who are having huge, huge health problems, financial problems, and they're really not showing up and doing, everything that they want to be doing and you expect them to be doing because of their unmet healthcare needs. So we experience as a society both the direct cost of healthcare and the indirect cost of healthcare because healthcare can be so unmanaged. So I feel like I've said a lot of very, negative things so far, but I want to talk to you about direct primary care, which for me, as I talked about in my career so far, has been a light at the end of the tunnel and is what I consider to be the strongest alternative to the current primary care system that we have right now that is disadvantaging both doctors and patients. I have this typical care journey up here on the slide. You can read through it, but I want you to think for yourself about the last time you visited a fee-for-service primary care doctor, whether it was for you or, taking a loved one or your child. How did you make the appointment? How long did it take on the phone to call someone and make an appointment? How long did it take to get the appointment? Did you wait a week, a couple weeks, a couple months if you were a new patient? How long did you wait when you got to the clinic? Was it 5 minutes, 10 minutes, 30 minutes? Did the doctor spend a lot of time with you? Do you feel like they would remember you if they saw you on the street afterward? Did you feel like you got to talk about everything that you wanted to talk about? I bring this up because, in my opinion, primary care has become undervalued because primary care physicians right now have such huge panels. It takes so long to see them, and they can see patients for so little time. They've effectively become very, very well educated referral machines into larger systems that they're affiliated with or other specialists because they don't have the time to care for patients. If you look at a journey for a direct primary care patient, it's completely different. So let me tell you a little bit about direct primary care. It's a relatively new model. There's talk about it, starting about 10 to 12 years ago, that calls back to a really old model of the family doctor. Direct primary care physicians don't get paid through insurance. They get paid a monthly flat fee, either by their patients themselves or their patients' employers. It's affordable. It's not hundreds of dollars. The average cost across the United States is about $75 per member per month. And for that simple, flat, affordable membership fee, you get total access to your DPC. Most direct primary care physicians don't charge for any visit that you would need, any virtual care. Many of them include basic labs, small procedures within that membership. So when you start thinking about your healthcare needs, whether it's a sprained ankle, an ear infection, just your annual physical, there's so many things that we're going to urgent cares, emergency department specialists for, that can all be seen by primary care doctors when they have the time. Direct primary care doctors have left the system because they really want to build a relationship with patients. They want to practice to the top of their license, to the top of their ability. And they don't want to be on a fee-for-service treadmill. I don't think any clinician out there who has gone through 14 years of undergrad and med school training and residency wants to be referred to as a referral machine. It's not satisfying. It's very stressful, bringing yourself to every 7-minute chunk of your day, your whole self, to think about people's problems and their health. It's exhausting. And that's why there's so much burnout among primary care physicians. Here are some numbers about direct primary care. If it's a new concept, it can be really hard to believe that this is true. But these are some numbers that are based on surveys of direct primary care physicians and give you a picture of what DPC is. So as I said, the average prices are $65 to $80 per member per month. So if me and my husband were members, I would pay, $80 a month and he would pay $80 a month. So usually it comes up to a little bit less than $1,000 a year. In some areas in the United States, the cost is more around 60, and some it's more around 100. If it's more urban area, there's less DPC, but it's not concierge based, even though this is a concierge like product, and there's no insurance bill on the back end. So there's not an additional copay that you have or additional fees that an employer would have to pay. Most DPCs, as I said, there's no copay when you visit. And the fees, when we looked at the fees from our perspective, we process payments at my company, Hint Health. The average fee increase is 1.5% over 3 years. So the fees aren't growing, they stay pretty flat. It's very predictable for both individuals and employers. In terms of access is the real magic of DPC, because DPCs have about 600 patients, which is a third to a quarter of what fee-for-service docs have. So that's the real magic of DPC. They have the time to spend with patients on complex medical needs and are there when patients need care. Because you can't predict when you get sick. You can't predict when your kid falls down and has a goose egg on their head, and you don't know whether to take them to the ER or not. You need someone who you can talk to quickly, remotely. 99% of DPCs include phone, text, consults included in the membership, same-day appointments. 84% offer urgent care walk-in appointments. And for those who don't, they're on the phone with you to be able to say, put some ice on our head. Let's talk again tomorrow. Let's see how it is, and give you that medical advice right over the phone that you can't usually get, through your primary care, who typically needs a day to a week to get you in if you're an established patient. In terms of quality, 38 minutes is the average amount of time spent with patients per visit. if you look at what fee-for-service doctors can code, 35 minutes is the maximum they can code. And they have to prove that you're really, really, really sick to be able to get paid for a 35-minute visit. There are things that you might want to talk about with your DPC, weight loss, family issues, mental health, that are going to take more than 7 minutes, but that it's not an option in fee-for-service. And it might, if doctors can't code you to that level, they're not going to get paid by spending that time with you. DPCs have the time to spend with their patients. In fact, I've heard some patients say, I didn't understand why my doctor kept talking to me. It's such a different experience than in the fee-for-service system. Fewer patients, and 68% of patients comply more often with preventive care guidelines in DPC than in fee-for-service. In terms of patient experience, the average member NPS, Net Promoter Score, is over 70. In traditional fee-for-service, it's usually about 30. DPCs are so much happier, so much better satisfaction than in fee-for-service. If you think about being a caregiver, oftentimes people say you have to have your tank full to take care of someone else. If you think about what primary care doctors are doing, they're taking care of patients all day long. They're hearing, the good, the bad, the ugly. And when they're happy, they're better clinicians. And that's what we see in direct primary care. So one of the things about direct primary care that we get asked a lot about is, how many direct primary cares are out there? Is there any in my community? Like, what is this even? And as I said, it's a relatively new movement, but I wanted to share some statistics from our DPC trends report that Hint Health published last year, last year now, to show you some statistics about the growth of DPC. Because you may have looked into DPC, 4 or 5 years ago and thought that's so niche, it's so small. And I want to show to you it's really growing and really catching on. So this QR code is here. If you're interested in downloading the DPC trends report, you can do that to download it and read it all yourself. So it's a great report if you're curious. So the popularity of direct primary care as measured through Google searches is growing. This is a fun one because, Google is where we all go with our real questions. The number of DPC states or DPC favorable states with DPC favorable laws has increased over the past five to 6 years from just a handful to over half. Most states here have specifically call out that direct primary care as it's defined can be practiced and is not defined as insurance or HMOs. In the states that are grayed, there's still lots of DPC going on, lots of employers using DPC, and people working diligently to get that favorable regulation passed as well. The percent change in DPC clinicians over the past 5 years from 2017 to 2021 is 159%. So we're seeing, and even through COVID, we saw growth rates of 25 to 40% year over year. And while it's still small, we're seeing, as primary care doctors get fed up with the fee-for-service system, as residents graduate and kind of have two choices before them, are they going to go into the system where they hear people are burnt out, dropping out, really stressed out, or go into, a system where they can actually take care of patients, have a life outside of their practice. More and more residents are picking DPC and more clinicians are switching over to DPC. You can see some of the states here that have the deepest penetration of clinicians per 1,000 PCPs by state. So we're seeing in states where there's more clinicians, more come because people really hear about it and it's a big network effect. So we're looking forward to seeing that network effect happen in other states as well. active DPC members per 1,000 in the United States. So I always index to 2019 because that's the year I started at Hint. And I remember when I started, I didn't really know much about direct primary care. The people who I worked with were like, what is that? That's never going to work. It doesn't sound even real. And so I always think, in the time I've been at Hint over the past 3 years, from 2019 to 2021, the number of people in the United States who have DPCs has doubled, which I think is so cool and so powerful. You can see some of the active DPC members per 1,000 really mirrors the penetration of DPCs. We see DPCs really filling up as they grow. Employer-sponsored DPC is an interesting question, and it's one that I've been working on for several years. So DPC started out as a patient paying a doctor for their membership, very, one-to-one relationship. But patients often work in businesses or can be business leaders, and DPCs have recognized employers as a great way to grow their patient panel. So employer-sponsored DPC memberships have grown dramatically over the past 5 years. We see that you can see the darker blue line is the growth rate of employer-sponsored, and the lighter blue line is the growth rate of retail membership growth. So DPC is catching on like fire with employers, and I think this is for several reasons. Some are just a differentiated benefit, really caring about their workers' health, but also the effect that DPC has on overall cost to the employer, which I'll get to in a few minutes. Most DPCs are working with smaller companies. It's easier for DPCs to work kind of on a one-to-one basis with smaller companies under 50, under 25 that fit in better with their panel. They can work one-to-one. Larger companies who are working with DPCs typically are working with either multi-site DPCs or networks, and DPC networks. And as more companies have spread out worker populations because of virtual technology and COVID and just kind of the nature of businesses being in multiple locations, networks are a key way for employers to implement DPC across their population. There was a great study done about 2 years, I guess it's 3 years ago now, I need to get my brain into 2023, that looked at the risk-adjusted healthcare claims cost and utilization between about 2,000 members, half of them in DPC and half of them not in DPC. And this is an independent study commissioned by the Society of Actuaries, conducted by Milliman. So really the best in the game in terms of healthcare cost analysis. And what they found was that the total claim cost reduction for the population using DPC was 13%. So when I worked in healthcare, worked in health insurance, and worked in, helping employers and the plan reduce costs through risk arrangements, a 2% decrease in claim costs was massive. So a 13% reduction in claims cost is just, incredible. And where we see that claims costs coming out are reduction in outpatient charges. The reason that is because DPCs transition from being that referral machine to being the first stop in the holistic stop and to their patients. And because DPCs, have time, they can do the things in that PCPs and fee-for-service can't do in 7 minutes. They can call their friend who's a dermatologist and get a second opinion. They can look into research to see the most recent research. They have that time to take care of what's usually going into specialty care. A 40% reduction in emergency room utilization. So this is a key mechanism where DPC can reduce claims costs, because usually people when they go to the emergency room, we just wanted to check. We just wanted to be safe. We didn't want something to happen. It seemed bad, but without medical advice, you can't really know, and you can't know for yourself. So a lot of low level things that turn out to be nothing end up in the emergency room. And a lot of emergency room visits end up as observations or as inpatient stays. And that's not a coincidence. It really can vary by hospital and their policy, and whether they're not-for-profit or for-profit hospital, what their numbers are, how much their beds are, full, rather than how sick the patient is, because you get into the hospital finances driving decisions about people being admitted versus the care that they need. So this can add up really quickly for employers if people are using emergency rooms instead of going to the right site of care. But for most of us, we can't call our PCP after hours. We can't message them after hours. And a lot of things happen in the evening, in the night, in the morning. And so we go to the emergency room. With DPC, the after-hour access and the that pre-established relationship, being able to make a call, get medical advice over the phone, prevents people from going to get care at the emergency room that they don't really need. And of course, if they need it, the DPC, as their PCP, will be the first one to say, go to the emergency room. And then we'll be following up with them the next day to see how they're doing. This is a very busy slide, and I apologize, but I did want to kind of call out some of, the table here, where we see reductions in risk-adjusted healthcare costs for DPC versus the non-DPC group. If you're interested, you should really download the study. I'd be happy to share it with anyone after this. The other way that DPCs can influence costs for employers and for individuals is through referral mechanisms. So many PCPs today are aligned with large health systems. Health systems refer to DPC as loss leaders. So another, not great name that DPCs get referred to as. They're not loss leaders. Primary care is the heart of healthcare. But for hospitals, buying up primary care doctors and then paying them to refer into their own hospitals, to their own specialists, to drive that revenue is a great way to, make money on the higher margin services that hospitals and clinically integrated networks, IPAs, whatever you want to call them, have. DPCs are independent, so they're really able to work with whatever network the employer is using, with their own cash pay network, with narrow networks, to make sure that when patients do need care outside of the primary care walls, they're going to the place that's most cost effective for both the patient and the employer. If you're, this is getting a little bit into the weeds, and I'm not sure who all the audience is out there, but I'll go into kind of an overview of several different ways that you can implement DPCs with larger health plans. In some cases, for small businesses, DPC may be the only benefit, or maybe alongside some voluntary benefits for groups that don't have to offer full health, ERISA MEC level coverage. So we always say you should have catastrophic coverage in addition to direct primary care. There's no replacement for that. But for employers who are looking to provide a benefit that's really meaningful, that really can change and help the health of their employees, DPC is a really strong option. DPC plus medical cost shares like Zion or Sedera go really well. What we've heard from medical cost shares is that sharing costs and requests go down when their patients have DPC. That's the same effect that you see, like fewer claims, less utilization when you have really good primary care. This can be appropriate for groups under 50. With medical cost shares, they're different than insurance, regulated differently. So they're not right for every group. They may not be in every area. Some are religiously affiliated, others are not. So it's a different option than insurance, but many small businesses find that it's one that's more affordable for them, and that employees like as well. DPC plus a traditional PPO is what we see a lot of employers going with. This can be fairly easy to implement. You sit a DPC on top of a PPO. It has positive effects in terms of reducing costs. What's really important about this combination, if the DPC is not integrated into the network, is that there's really good employee communication to get them signed up, seeing a clinician, establishing that relationship, because in the PPO, there's typically still that primary care benefit. And you want the employees to go to the direct primary care benefit and not to the traditional fee-for-service PCP benefit, or worst case scenario, both. My favorite is GPC embedded in an off-the-shelf plan. So we work with several partners. Some of these listed here, we work with other ones just listing Decent, Pop and Sana, Excel Health Plan. These are smaller plans that offer a full benefit of both a hospital and specialist network, but have DPC as the heart of the plan. It's an off-the-shelf option. The plan is built around DPC. DPC is integrated into the pricing. It's really the smoothest and most understandable option for employees. The cons can be that it does require a total benefit change. You don't get that, Blue Cross name on your card, which a lot of employees can look for. But once they experience the DPC benefit and see the difference between their experience in the old system and their the strong relationship in healthcare they're getting from DPC, usually, employees absolutely love it. Some employers are creating custom benefit structures around DPC that can be, exactly what an employer needs in one location, and they can work really closely with a DPC or DPC network. Obviously, it's a lot of work, and you have to have a certain size to make that customization make sense for an employer. So me and my team would be happy to talk through some of these other options. We have a lot of great broker and advisor partners who are doing these right now, who can also serve as resources. I'm going to peek into the Q&A to see what we have here before I go into Hint Connect. So, is there any data outcomes on what % of eligible population see a PCP annually in DPC partnership with the employer? I have 4 DPC specific case studies. When you have a primary health partner or Nextera or Strata publishing their own case study, there's data there. I know anyone who's publishing a case study is doing a really good job and a lot of work engaging employees. So the stronger you have education, employee engagement before open enrollment, during open enrollment, and then after the benefit is chosen, the better engagement you get. I would say 70% is considered really good. We want our goal at Hint Connect, and I think a lot of DPC's goals would be to get 100% of people in for an appointment within the first 1 to 3 months. Establishing that relationship is what creates the value downstream. Not everyone has the time or, to do that, or if they are really centered on the fee-for-service relationship and think, I'm not going to go until I need something. Whereas the education is all about establishing the relationship so that who's there in case you need something. So at Hint Connect, we spend a lot of time thinking about how to engage and educate both before, during, and after open enrollment, and work in conjunction with direct primary cares to make sure that outreach is happening and people kind of understand they have someone there for them. Do you have any examples of TPA or medical stop-loss premium discounts when DPC is utilized? Yes, we have know of a couple, at least 2 stop-loss carriers who are familiar enough with direct primary care that they're offering discounts when DPC is implemented, and that can really help offset the cost of the investment in primary care for employers when they're taking the leap from spending or maybe $20 PMPM to $60 to $80 PMPM on primary care, and hoping and hopefully believing that that cost will come out of other areas. Thanks for the questions. Happy to take more. So in the final part of this webinar, I'm going to talk about Hint Health, which is the company I work for. Hint Health has been around for about 10 years. We work with thousands of direct primary care providers across the nation. We started out as a billing and enrollment solution for DPCs because what our founders found was that all billing and enrollment was meant for claims. And when DPCs didn't submit claims, there really wasn't technology for them to be able to collect the monthly payments and manage eligibility and enrollment. So payment, eligibility, and enrollment are the core of what we do. Last year, we acquired Aero DPC, which is an EMR. So now we're a full integrated back-end solution for direct primary cares. And last year, we're really excited to announce we started a DPC network called Hint Connect. So Hint Connect offers employers a turnkey DPC solution, making it really easy to implement DPC for larger employers. What we were hearing from employers was over the past several years was a lot of interest in working with DPCs, but no mechanism for doing so. DPCs obviously are independent. They're working on their own. They may offer different services. They're not part of an insurance network. And that kind of broke everyone's, brains. Like, how do I work with them? How do I work with more than one? How do I even find them? How do I know if they want to work with employers? It can be, really easy to want to work with DPCs and really difficult to actually do that. There are some wonderful DPC networks out there. Some of them I've mentioned already. Some of I haven't. Persona in health in Florida, Hemp Nation in Atlanta. We have networks in Idaho, Pennsylvania, Southern Oregon, but a lot of them, unless there's one in your backyard and, most of your employees can be seen right there, it can be difficult to work with DPCs. So we created Hint Connect to connect the great work that those networks are already doing and work with independent DPCs who want to work with businesses. We offer DPC across multiple markets. We standardize the benefit across independent practices, so employers don't have to worry about offering differential benefits if people choose different DPCs. We educate employees about DPC, drive engagement, and track patient satisfaction and outcomes. So right now we have over 200 clinicians on our platform. We're hoping to double that next year. This is a list of services. It's not all inclusive, but when you think about, primary care, like we talked about before, a lot of people are seeing primary care for a sprain, making sure you get your prescription that you need, a UTI, but primary care under DPC can treat so many things. And this is just a brief list of some of the list of services that they see, conditions treated, a lot of the things that drive healthcare costs for both individuals and employers. This is our current network. We're in 25 states. We'll roll out to an additional 15 states in 2023. On the Hint Connect website, you can see our map with exactly where our contracted clinicians are right now. As I mentioned, we work, end to end, making sure that employers have the network they need so we can do custom network builds. We educate and engage employees. We want to be right there with you, and including bringing our clinicians in to talk to employees, to educate them. We have you make it really easy to kind of slot this material into larger benefits conversations. And then we're here personally to answer any questions that might come up with employees. We run Hint Connect on our core technology, Hint OS, that I mentioned before, that's been around for 10 years. So we make it really easy for employers to implement with an easy enrollment, eligibility, and management via our tool called Eligibility AutoSync. We can work either directly with an employer to get enroll, monthly or weekly lists of enrolled and terminated employees, or we can work with the TPA. We haven't found a TPA we haven't been able to work with yet. There are over 300,000 employee-sponsored lives on Hint OS right now through the relationships that DPCs have cultivated. So this is something that we really know how to do, and are excited to bring it to the Hint Connect network as well. We do single invoicing and payment for all parties. So your employees can be working with 2, 10, 200 DPCs. You get a single invoice, really easy to review, pay, and process. We're also working on reporting and optimization. So we know that reporting has been a challenge for direct primary carers working with employers in the past. With, we're in terms of reporting so oriented to claims data that without claims data, it's, it can be hard to know where to start. But speaking as someone who used to work with claims data, who always wanted clinical data to be able to really understand what was going on, I know that the power of claims data is multiplied when you have access to the EMR data. So we are working with our API integrated partners in EMRs and our own EMR to make sure that we're reporting to the employer of what's happening behind the scenes. To your question before, how many people are being seen? Are they the right people? DPC works wonderfully, both in terms of health outcomes and cost management for people with chronic diseases. So making sure that if the employer has identified those people, that message is getting to the DPC and vice versa, so that the employer has insight into what they're paying for. This is a standardization of services across DPCs. For those of you who come from the fee-for-service world, it's pretty obvious that you would want to standardize the services you're offering. But if you've worked with if you've seen one DPC, you've seen one DPC. When practices have the freedom to practice to their passion, you see DPC specializing in all sorts of different areas. Some of them are traditional areas like cardiology, others are functional medicine, food as medicine. You see people specializing in women's care, care for different communities. So we standardize a core set of services that we consider to be the heart of direct primary care. And we talk with every single clinician who's coming into the network, make sure that they can provide this, make sure that, they can meet all the criteria that we have for Connect, that they're vetted and ready to go for employers. So I have been talking for a long time now, and I'd love to take more questions. We also are available after this webinar if you don't want to ask questions right now, or you're seeing this after the fact, to answer any of your questions about direct primary care or Hint Health or Hint Connect. So I'll give it a couple minutes for some questions to come through. All right, well, thank you everyone for your time. I really appreciate you hanging in with me today. I'm really excited to be able to talk to you about this topic. Obviously, I'm really passionate about direct primary care. I think it's a solution for both our clinicians and kind of the health of our employees, the health of our country. And I think it's just everyone can benefit from direct primary care. So really excited to bring it with you today. David, thank you for the opportunity to present here, and I look forward to hearing from some of you soon.